your assessment and treatment plans, and then again, your encounter submission, which we talked about last time, but it's just so important that I included it again. So some of the cardiac conditions that we're going to talk about are AFib, atrial flutters, tachycardia, sick sinus syndrome, cardiomyopathy, congestive heart failure, angina, and hypertensive heart disease. First, we'll go to the AFib. Pretty much, let me just tell you that there are several different types of AFib and several different types of flutters. It's so important that you really code to the highest level of specificity. So we like you to move away from using unspecified codes. You're going to find that over the course of the next couple of years, those unspecified codes are going to be deleted. So you're better off now to get in the habit of specifying the type of AFib you have, whether it's chronic, persistent, whatever the case may be. And then your codes would be as listed here, your I-48.0, I-48.11, and then your I-48.20. Again, a lot of providers don't know that atrial flutters also carry a risk adjustment score. And again, you just make sure that you're documenting the type, typical, atypical, and then code appropriately. The biggest thing that I tell you every time, I'm going to just keep telling you, is that each time you document one of these conditions, it is vital that you reference any diagnostic testing or specialist reports that can confirm this diagnosis, and always, always, always document the status of the condition that day and any treatment plan. And again, if you are not the treating provider, you can certainly just say, currently under the care of cardiologist, continue with care or continue with treatment. That's certainly appropriate. Again, if you're not the treating physician. Also, I wanted to tell you that when you code for AFib or the flutters, regardless of the type, the score is the same. So don't think chronic carries more weight than persistent, or typical is more than atypical. It's all the same. There's one score for AFib, regardless of the type. There's one score for flutters, again, regardless of the type. Also, tachycardias, they will also carry a MRA score. So just know that your supraventricular is I-47.1 and your ventricular is I-47.2. Again, either one of them is the same weight, but either one of them will get you a score. Sick sinus syndrome. In the past, if your patient had sick sinus syndrome and had a pacemaker in place, you were not allowed to bill for sick sinus syndrome. As of March 20th of last year, CMS and the coding clinic changed their mind. You now, regardless of the presence of the pacemaker, you are indeed entitled to bill the sick sinus syndrome with the I-49.5. And then, of course, if they have the pacemaker, code the presence of the pacemaker, which would be your Z95.0. The presence of the pacemaker does not get you a weight or a score, rather, but it is important that you document it should the patient have one. Again, reference any diagnostic testing or specialist report that confirms it, and always, always, always the current status and any treatment plan. Your cardiomyopathy, typically we will bring that to the attention if we see on the echoes if the EF is less than 50. There's a couple different types, again, just like anything else. You have your dilated cardiomyopathy, is one common one that we see, which would be like the I-42.0. Another one I always point out is the alcoholic cardiomyopathy, which would be I-42.6. Should you have a patient that has alcoholic cardiomyopathy, I would also encourage you to code for the alcohol dependency, which will get you an additional score above and beyond the cardiomyopathy. So just remember, that's why it's so important to really document the exact type that they have, because sometimes it will spawn another condition and or another score. Your congestive heart failures, same thing. You know, code it to the highest level. If it's systolic, if it's diastolic, if it's combined, if it's acute or acute on chronic, I give you the codes here. Again, it's regardless of the type, it's one score, but it is in your best interest to specify the type because, like I said before, as the next few years come to light, these unspecified codes, CHF unspecified, they're going to start to go away and they're no longer going to be valid codes, or they're going to be a valid code, but they will not have a score attached to them. And we've seen that already with some of them over the past year to 2 years, that a lot of the unspecified codes have come off the MRA list and no longer carry a weight. So they're really encouraging you to make sure that you're documenting the exact type of congestive heart failure. And again, make sure you're documenting the current status and the treatment plan. It is so vital that each progress note, if you are documenting a condition, that you have applicable support and the treatment plan, whether you're treating it or somebody else is treating it. It's always vital that you have that information on your progress note that day, because should they be audited and you have no support or treatment plan, that condition will be disqualified and deleted from the patient's score. Angina is another condition that we see a lot. The two most common, obviously, are stable angina, which would be your I-20.9, and then your unstable, which would be I-20.0. Let me just say to you that the unstable angina is really reserved for the actual acute episode only. Once the patient becomes stable, then you would revert back to stable angina. Don't continue to use the unstable, because that is more of the immediate acute episode. There in 2019, I believe, started the combination code, which is cardiac atherosclerosis disease with angina. So if you have a patient with CAD and then they have angina, you are required to use the combination code, which would be I-25.11, either 110 if it's acute and unstable, or 119 for stable. I see this a lot of times where the providers will code CAD with no angina, and then the next entry in their assessment is angina. That would be considered an error, and because of the conflict, you would lose the score for the angina. So make sure if they have CAD and they now have angina that you're using the combination code. We just went through this with a couple of our practices, and the health plan actually did delete their angina, and they did lose the score because their assessment contradicted each other. One said CAD with no angina, and then it said angina. So please just be very careful when you're coding and you're documenting in your assessment. It's so important to go back through and make sure that your diagnoses are not contradicting each other. Because lately that has been a big thing.
Difference in the weight between stable, unstable, and CAD with angina?
No. Again, there's one weight for angina regardless of the type. But again, I've seen where providers continually code unstable angina, and then the record is audited, and if in that progress note, if you're using unstable angina, and in your physical exam everything is normal, and there's no other evidence in your progress note that day, your unstable angina is going to be disqualified because there was no support in that note as to what the condition was. Was there chest pains? Was there an episode where they needed to go to the hospital? Those are the things that an auditor is going to look for, and if it's not in that note, they're going to disqualify and remove the score for the unstable angina. So please just be very cautious that you're only using that during the acute episode. This is a big one that I really want to talk about, is hypertensive heart disease. A lot of providers document and code hypertensive heart disease with heart failure, which is the I11.0. When you use that code, there is a coding guideline that says you must also document and code the heart failure. So if you are using code I11.0, the only qualifying heart failure code is congestive heart failure. So you must also document the congestive heart failure when using this code as a separate assessment in your assessment area, and code it with the I50 series, whether it's systolic, diastolic, whatever that type of heart failure is, you are required to code it. If you use I11.0 and you do not code for the CHF, it'll be disqualified. Again, the same thing, hypertensive heart disease with heart failure and CKD. Again, you have to document the type of heart failure using the I50 series, and you also must stage CKD. In this case, in the I13 series codes, once the CKD comes in, you will get a second code for CKD stages 3 through ESRD, and you are required to document the stage. If you don't document the stage, you've lost the code for the CKD and you've lost the score.
So Kerry, I don't understand this. This is
this is a tough one.
I can understand the hypertension, heart disease with heart failure, but hypertension, heart disease with heart failure and CKD, that's like putting three things together. They may not be related. So can we put like hypertension, heart disease with heart failure, and then CKD stage 4?
You also have to put congestive heart failure with the I50. So hypertensive heart disease with heart failure requires 2 codes. Hypertensive heart disease with heart failure and CKD requires 3 codes. You cannot use these codes alone. And I see so many providers do that, and you're not going to get credit for it.
You mean 3 codes? 3 codes, one for hypertension, one for heart failure, and third one for CKD.
For the stage of the CKD. Okay. Yes. So just know, really just know if you're documenting hypertensive heart disease with heart failure, that should trigger you that you just, as long as you know you need something else, your billers, your coders, somebody else can help you with what the coding guidelines is. But anytime you're using I11 or I13, there's more work to be done. There's either one more code or 2 more codes. And then of course, if your patient is ESRD or stage 6, you would also document the status for the dialysis.
So let me understand, understand the audience too. So if I say hypertension, heart disease, problem number 2 is heart failure, problem number 3, chronic kidney disease, and then I put 3 code, that will satisfy you, is that right? Or do I need to put all 3 in one line?
You could put it all in one line. You could put it in 3 lines. The information, I mean, when you click on your EMR system, you're going to click the hypertensive code. So then the next entry would be, you know, your CHF. And then if it's with heart failure and CKD, your third entry would be the code for the stage for the CKD. So it's like if they had stage 3 CKD, you would end up using I-13. You would end up using I-50 point, say if it was diastolic, 0.30, and CKD would be the N18.3. You would need all 3 of those codes documented in your progress note.
Very good.
Okay. I know Dr. Agarwal had asked me for the weights for some of these conditions, which I don't typically include in the slides, but if everybody wants, I will go back after tonight, and I will begin to revise the slides and put the weights for each one of these categories, if you would like that.
I think that will give us some idea. So if you miss a higher weight and you put a lower weight, the comparatively people will understand that, you know, don't forget the higher weight diagnosis.
Yeah, I can, you know what, I can put it out there. What I'll do is I'll work on it tomorrow, and for all the slide presentations, I'll go back through, and for every code, I'll add the category and the weight. And then I'll also send out a document that what each category, what the weight is for that category. For example, you know, in category 59, which is major depression, that, you know, so many different conditions fall into that category. It could be major depression, it could be bipolar, it could be, you know, mood disorders, it could be a number of things. However, it's only 1 score for the category. So, you know, so I can give you the list of what the score is for each one of those categories, and then I'll go back on each one of these slides and put what each category is, and I'll also add the weights there as well. So it's just a little bit more user-friendly for you. Those are pretty much the most common MRA heart conditions that we see. The other one that I didn't put on here was pulmonary hypertension. That's kind of missed a lot. We use a guide anytime the pressure in the echo is above 35, you are entitled to code as pulmonary hypertension. So I just wanted to throw that out.
Let me bring this up. The pulmonary hypertension.
Yeah.
When we make the diagnosis of pulmonary hypertension, that's a very serious diagnosis. So the pulmonary hypertension of 35 in a patient with hypertension is basically a secondary hypertension, which is secondary to diastolic dysfunction, which is not basically a bad disease. But primary pulmonary hypertension is a major problem. So when you say pulmonary hypertension, you just make the diagnosis of pulmonary hypertension, or do you go further? It's a secondary or it's a primary pulmonary hypertension?
As a coder and a non-clinician, I bring it to your attention, the results of the echo, and allow you as the clinician to diagnose primary or secondary, or if the report is, you know, if I'm reading it from a cardiologist and he calls primary or secondary, that would be my recommendation to you. But we just use the benchmark of 35 to call it. And if it's not specified primary or secondary, coding guidelines require you to default to secondary.
Okay, very good.
Okay. So I would, as the coder or the reviewer, I would bring to the provider's attention and query him and say, here's the echo, it's, you know, 35, you know, your patient, there's underlying conditions, would this be a primary or secondary? And, you know, I would look to you for guidance. In the absence of being able to query the provider, I would have to default to secondary. However, primary or secondary in the world of MRA is the same score.
Great.
Okay. So here we go with our documentation, best practices. all your diagnoses submitted for risk adjustment must meet the following criteria. They must be documented during a face-to-face encounter, and in the current environment of COVID, it has to be a video visit. So it's either a face-to-face visit or a video visit is acceptable to submit MRA. You must have full and accurate documentation. All your conditions must be supported. They must have current status and treatment plan. And just remember that each visit or each progress note is a standalone document. So each condition that is in your assessment has to be supported by some type of clinical evidence or reference to the treating physician in that individual note. It's no longer counts if you have the specialist report in your chart, but you don't reference it. That is unacceptable. You have to reference that the patient is seeing the cardiologist, you know, currently under the care. It has to be written in that note. Now that CMS is going from this data submission, they're now going from the RAPS file to they're taking all of their information and MRA conditions based solely on encounter data. It's become quite evident, and you're going to hear throughout the course of the next couple of years that it is your documentation and your progress notes that are going to become so important, because those are the things that are going to be audited. They are going to pull your progress notes and make sure that that note supports every condition that you build that day. And if it doesn't, they're going to start deleting your scores. So it really is vital that you really start concentrating and reviewing your notes prior to, you know, billing them out, that, you know, you've coded everything that you've talked about in the notes. A lot of times I see conditions, they're talked about chief complaint, and they're never brought down into the assessment. And at the same time, I see a lot of conditions in the assessment that are never addressed in the note, and they have no status, they have no treatment plan, that they've just been copied and pasted from a problem list. And that currently is unacceptable. They have to have their current status. Otherwise, CMS looks at it as if the condition was not assessed that day.
So, Carrie, let me put you in a situation here, like a patient
Sure.
who go to 5 different doctors. You know, go to cardiologist, go to pulmonologist, go to cancer doctor, and then go to orthopedics. And then you have a primary care physician.
Yes.
And primary physician may not have all the records from all the specialists. Now that patient comes to primary care physician. So if the oncologist code the patient and bill for the patient, that will go to the Medicare computer, is that right? So
correct.
Total weight of the patient will still be high, even if the primary care physician don't code everything else. Is that right?
Yeah, I mean, if your specialist, for example, in that scenario, if your oncologist is coding and submitting for the cancer, you are going to get the score for that cancer. However, you know, if they're not seeing the specialists regularly and the specialists are not submitting the conditions, you are going to lose the score if you don't submit them. So I always tell the, you know, all of my primary docs, don't rely on the accurate coding and billing of another physician when it comes to your reimbursement.
That's great. That's very clear now. So we basically, if you are in a managed care environment,
Yes.
you want to keep your practice going, you want to make sure you're referring doctors or specialists sending the reports, and then you're putting all the data together at least once a year in the impression and using all the diagnosis for billing. Right?
Correct.
That's the only way to Medicare will know that your patient is sicker than
correct.
Yeah.
Correct. I mean, in the case where a patient with congestive heart failure, if they're stable and everything is good, and they haven't been to the cardiologist in a while, that then if you don't document it, you're not going to get the score. Your score is going to go down from the previous year. So it's always vital that the primaries, really have a well-rounded knowledge of all of the chronic conditions, and they're documenting them at least once. And again, you don't have to be treating them. You certainly can say, followed by, cardiologist, or, continues treatment with, the pulmonologist, or whatever it is. Just reference who is treating it, and that is enough evidence in your chart that qualifies for you are monitoring the conditions. You are monitoring their
question here from the chat. The question comes from Dr. Vinod Sacheti. And do the codes differ if the patient is in the outpatient setting, or in nursing home, or in a hospital?
No, they do not. Diagnosis codes are diagnosis codes. They're across the board. The only difference is when you get to inpatient versus any type of outpatient. Hospital billing is a little different. The hospitals are allowed, their guidelines are a little different. They are allowed to bill rule-out diagnosis codes. So if they're ruling out CHF, they can document CHF because they are working, the diagnostics to either confirm or deny the condition. The providers, however, in the outpatient SNF or office setting, are not allowed to bill rule-out diagnosis. In the absence of a confirmed diagnosis, you can only code for signs and symptoms.
That is totally unfair. I mean, that doesn't make any sense.
Well, I understand that.
The same doctor.
I understand that, but that's the rule.
That is something different.
Yeah.
Same doctor can diagnose something else in hospital compared to in his own practice. Very good. So
yeah, the other question was, can anyone different codes for sepsis, pneumonia, CVA? So I can talk a little bit about sepsis. Sepsis is one of those acute conditions that you would only see in the hospital setting. Typically, I've never seen it coded in a physician's office. It's just something that typically you don't see. It actually does carry an MRA score for the sepsis. Pneumonia obviously can be coded in any setting. Pneumonia unspecified does not have an MRA value. However, once you start to specify it and the type of pneumonia, there are some that do qualify for risk adjustment. CVAs are never coded in a provider's office. The I-63.9, never, 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 never. That code is only used in the acute care setting at the time of the CVA. Once that is over, you must code history of CVA. Now, having said that, any hemiparesis as a residual effect should be documented, and that does carry an MRA score. So, if the patient is left with left-sided, weakness, or, monoplasia or hemiplasia, you can certainly code that as the late effect of the CVA, and then you would get a score for the late effects, but you cannot code for an active CVA in your office. Oh, malnutrition codes. So malnutrition, we have a rule that malnutrition for the population of 65 and over is at a BMI of 18 and below. You can code them in the office. You need to, beyond coding it, obviously, you know, your support would be, you know, one would be the BMI. You want to talk about, you know, discussion about diet or, you know, additives to, you know, to the patient's diet. The other malnutrition that we see a lot is more so we see it in your cancer patients, cachexia, which is more of a wasting type of thing. That's not so critical to the guideline of the BMI being 18 or below. That really has more to do, you know, with muscle mass wasting, that kind of thing. It's both applicable in the office. I hope that answers your question.
So for a person with albumin of 1 or 2 will not be a malnourished patient?
Yeah, you can, you know, if they're albumin, yes, that's also a guideline. You know, and we look for that, but typically, you know, we see malnutrition. The first clue in the chart is the low BMI, but certainly I do have a provider that only goes off the albumin. So that is acceptable too. Okay, so the next question in the chat is about Alzheimer's dementia. They are recent conditions added to the MRA risk adjustment. So always make sure you're coding for your Alzheimer's diseases and if they have any corresponding dementia. And then of course, you know, the type of dementia, whether it's related to the Alzheimer's or if it's just straight dementia, you know, you just want to, you know, make sure that you're documenting what type and if they have behavioral issues associated with the dementia or the Alzheimer's. But either one, as of 2019, have been added to the MRA list of scorable conditions. So make sure you're documenting those as well. Those are some good questions.
Okay, do you have more slides or this is it?
No, that was it for, oh wait, I just, yeah, the final impression and plan, which is the same ones we go through all the time. Make sure all your conditions and diagnosis that impact your patient's care are documented. Make sure that, you know, all the conditions are documented. You either are monitoring, managing, evaluating, you have assessed them, or you personally are treating them. Document all coexisting comorbidities. Make sure you have a treatment plan for each diagnosis. Document, you know, any types of referrals or for diagnostic testing or specialists or, you know, anything that you're ordering that day also should appear in your note.
So Kerry, let me ask you a question. So I am a cardiologist or maybe primary care physician, or this patient has cancer of lung undergoing chemotherapy. So the impression, can I say that small cell carcinoma of lung being treated by specialists and then coding, or do I need to do a physical or maybe history or do something else in it?
No, I would say, you know, small cell, you know, lung cancer, actively undergoing chemotherapy.
The impression.
That statement is enough.
Okay, very good. Very
good.
As long as you add all the diagnoses which you're not treating, but you know somebody treating it.
Exactly. Just tell us who's treating it. Okay. Yep. Just tell us who's treating it. You know, and that's sufficient. One last thing before I end my little few minutes here is I wanted to make sure that everybody is aware that just as January 1 every year, CPT codes change, some get deleted, some get added, there's new codes that are added, some of the descriptions are revised. Every October 1, the diagnosis codes do the same thing. So this coming October 1 will be the new edition of diagnosis codes. Now, you know, 99.9% of them are going to stay the same, but there have been 450 new diagnosis codes added this year. there have been some deletions and there have been some modifications to existing ones. My advice to everybody is to make sure that your systems, whether your EMR systems, that company is required, make sure that your systems are updated and you are using the current codes. It is so important, because if you're using a code and it was possibly deleted, number one, you're going to get rejections. You're not going to get reimbursement. And it's probably, that code has been deleted because there's a new code that could potentially have an MRA score to it, and you're not aware of that. It's just vital that you use the most up-to-date codes, and just know that the new ones are coming out October 1st.
So the most people have EMR, it's automatically done, is that right? The EMR vendor should bring this.
The EMR vendor should do it. But just make sure you can spot check. I think I'm going to, in the next couple of weeks, I will have a list of the revisions and the additions, and I can send them out. And, it's a good idea to have one of your billers or one of your office staff to spot check. You don't have to go through every single, one of the 453, but you should spot check some that are important to your practice and make sure that you're using them.
Carrie, you can, in the next meeting, you can enlighten us for the new codes. That would be great. Yeah. So I see, David, are you ready to say something about this coding? You gone through?
I see David had a question.
Yes. David has a question. Does the
In
EMR...
Dr. Agarwal's example, would you want to see a progress note from the specialist annually to support the cancer diagnosis in the impression? Okay, so that's a great question, because you can only code cancer while the member is receiving active treatment. For example, for the patient who had lung cancer, once her chemotherapy and/or radiation treatment has ended, you can no longer code cancer. You can only code a history of cancer. Now, that's not saying that they're cured, but you can only code the cancers during active treatment. And I think we talked about that in like the first one.
Angela Samuels asked the same question. If cancer is remission means patient does not have a sign of symptom, but you're getting suppression therapy, like suppression therapy for cancer, for breast cancer. Would that be active?
Yeah, for if the patient has breast cancer and they're on tamoxifen for the 5 years, that entitles you to continue to code the breast cancer. The only other one is for prostate cancer if the patient is getting Lupron injections. Then you can continue for as long as they're getting the injections and as long as they're taking the tamoxifen. All of your other organ cancers you have to stop coding active cancer once treatment has ended. If they have colon cancer and they have a colon resection and it required no additional treatment after that, well, outside of the 90-day post-op period, from the surgery, then you have to stop coding colon cancer. It becomes history of colon cancer.
Good. David, do you want to enlighten us a little bit? You want to add something you want to add?
No, sir. There's another question, Carrie.
What's that?
On the EMR.
Does the EMR vendor highlight weighted versus unweighted codes? I have only seen a couple, and I do believe it's an add-on additional cost from the vendor to have that module put in. I know ECW has it, but I've only seen one provider who has that module added. So,
Lou, I see your comment. Do you want to say something, Lou?
depression.
So what we're going to do is everybody's open. Everybody can unmute and ask questions if they want to. So
Sure.
Carrie's here to help you. I think there was some question about depression. Could you give us some ideas how to code the depression, when to code depression, when not to code depression?
Yes. the first time that your patient is diagnosed with major depression, most providers code it as major depression single episode because it's the first episode. You must stage the severity. If you do not stage the severity, you do not get a score. After the first time that patient has ever been diagnosed with major depression, from the second time for the rest of that patient's life, it is major depression reoccurrent. And then again, you would stage it. So the guidelines for major depression is if you are documenting acute symptoms that day, and you know you need to hit 5 of those 8 qualifiers, having to do with, you know, sleeplessness, disengagement, you know, weight loss, all of those 8 parameters, you must document at least 5 of them that within the past 2 weeks. Most people use a PHQ-9, but in lieu of that, as long as you're documenting acute symptoms that day, then you must stage mild, moderate, severe. If that patient comes in and they are feeling good, they're on their treatment plan, you know, everything is going great, they're not having an acute episode, the way you code that is major depression reoccurring in partial remission. And the partial remission is due to the treatment plan, meaning that they're not displaying acute symptoms at the present time. But once a patient is diagnosed with major depression, that is a code that stays with them for the rest of their life. Even if they no longer are treated for it and they're considered in full remission, major depression in full remission still gets an MRA score.
Okay, so now you can see the chat questions from
Yeah.
David and from Vinod Sacheti.
There was a time when physicians couldn't document memory to harm the patient's lecture. There are some providers that are a little standoffish about documenting dependency conditions and mental disorders due to health insurance or employment status, things of that nature. My response to that is, if it is a valid condition, it is your responsibility as the physician, if you are treating it, to document it. You know, there's also other conditions like rheumatoid arthritis, you know, that really will disqualify patients from life insurance. But if it's a valid condition and you're treating them, I mean, you're taking risks when you treat these patients for these conditions, and you're developing treatment plans, and you're required to document those. So while there are some times that it may have some adverse effects on other things, if the condition is valid, you really are required to document it as such. Now they're asking about codes for different stages of hypertension. And I guess hypertension in the coding world is hypertension. When you get into hypertensive heart disease with heart failure, that would be not necessarily stages, but you know, you would do a type, whether it's systolic, diastolic. Some providers do stage it as, you know, class 2, class 3. You know, it's not required to stage hypertension. But if you are so inclined to do it, obviously the more documentation, the more specific, the better. It does not change the MRA score. Diabetes in the office. Diabetes, everybody documents diabetes in the office.
So I think we know the
yeah, we could go on and on.
Good job on diabetes last time, and so
Yeah.
the audio is still video is still available on the website. The whole
Yes.
thing.
Okay,
Very well done.
I got it.
Yeah.
Okay, thank you,
Yep.
Subodh.
Very good. So let's see, we got about 14 minutes more to go. And anybody has any question about anything, please go ahead and talk about it. So If nobody, then I'm going to start talking about it. So basically, I recently, let's see, open this discussion and everybody can join in discussion that, should you keep your patient in Medicare fee-for-service system, or should you put them in your managed care plan? What should be the better way of doing for the patient and for you, or first for the patient and then for you? Anybody want to take that discussion and talk a little bit about it?
So both, can I say something about that one, if you allow me to?
Yeah.
Yeah. So we managed Medi. We have to just tell it's our moral duty to explain to the patient what is managed care versus regular Medicare. What they lose out if they go to managed Medicare. So it's like October is coming now. This is the perfect time to discuss managed Medicare Advantage plan, whether it's from Clover Health or Cigna Health versus keep the Medicare. I go over those things on daily basis in my practice. When somebody asks me that I don't have secondary insurance, what should I do? I said, okay, there are different level of Medicare insurance. So I have folder for like 3-page folder where they can reach out, how many different kind of insurance, what are different plan from A, B, C, D, E, F for Medicare insurance. So you try to tell the patient is in best interest for their health is to keep the Medicare and buy the Medicare insurance if their wallet allow them to. If it doesn't, then it's a different story. Then they have to choose Advantage plan. Again, Advantage plan also, which one is better? One is better, slightly better than the other one. So United Health versus Aetna versus Blue Cross Blue Shield. So it is our duty in office to educate them what they can get out of it. So like when somebody goes to Aetna Medicare, it's worse. In our place, they do not allow them to go to rehab for like a couple of days. They don't even get authorization to go to subacute rehab for sometimes 3 days, sometimes 4 days. So because finally case in
So let me tell you my experience. I think you're getting in and out, Vinod.
And me or anybody else as attending has to do peer-to-peer review with them. So Aetna is worse, United versus Blue Shield. Go ahead. So take on management, regular Medicare.
So let me tell you, I have multiple patients who don't know what they're getting into. And when they come in, they say they need to change their medication because their insurance changed or something happened then. And basically, they don't realize they're losing freedom for the price. So most patients don't know that. So who should tell them? Because the doctors don't want to talk about it. There was no other agency going to tell them that. And the advantage will keep talking and selling it because they're going to make profit from it. So
True.
So somebody has to say that, listen, where the truth is.
So we as the doctors has to, doctors, I would say doctors would be the first person to tell their patient what is good and bad about regular Medicare versus managed Medicare.
So please come on and talk about it. If anybody want to say anything in addition to it, we basically, most physicians stay out of it, but I think time has come, they need to really actively get involved and protect their patient. Patient can make the decision, but it should be an informed decision. That once they change that, they have to change the doctor. The most important thing which I didn't know, which David told me about, that once the patient go to managed care, the patient and the physician relationship changes. They want the patient, not you. But once you get out of that plan, you cannot see that patient. Is that right, David? Can you explain me that?
Yes, sir. So many physicians have great relationships with Medicare Advantage, and only after seeing it for 10 years did we see this happen occasionally. But once a patient goes Medicare Advantage with a specific plan, the health plan has all of the power. And that might be okay, but every once in a while we've seen, the health plan will terminate a significant population of physicians from the contract and then move those patients to other physicians. And then that physician, they talk to the patient and the patient says, hey, I don't have a choice. My insurance says I can't see you. And then they lose the patient and they have to fill those patients in the practice. But we've seen that happen a few times over the years, and the physicians sometimes forget that when they go Medicare Advantage, the patient the insurance company has a lot more power and control. The other issue is that some health plans will hire physicians, and maybe that'll happen more often when they have employed physicians for the health plan versus the patient staying with independent doctors.
Very good. Okay, so I thought a lot of people will discuss this. So anybody else has any other experience, a good or positive experience about things like that, getting involved in decision making to help the patient? What's the right thing to do? Because I see this story after they had done the damage, and then they come to us. So listen, I cannot take Renexa, I cannot take Alocus, I cannot take this because my health plan changed. And that is basically patient was not told that that's what's going to happen to patient. And so how do you handle that? Do you tell them, call the Medicare and say, listen, you want your Medicare back? Biloji, what do you do in a situation like that?
It's very difficult. Once they get enrolled sometime, the whole year they have to stay with managed Medicare. So as you just said, most of the patients tell you once the damage is done, they come to our office, I have changed it to Clover Health. Okay, how did you change it to Clover Health? Because I see your name there. So they change, because the agent who goes to those elderly people and change the insurance, they tell them, yeah, no problem, your doctor is in the book. Doctor alone is a book, PCP might be in book, doesn't mean all affiliate of consultants are in the same book either. So then they have to suffer for whole 1 year, and then next year I tell them to change it. It's very, very difficult. Now in New Jersey, like some hospital system, 2 hospital system has came out with their own insurance plan. So it's going to be really, really difficult for patient. So they're going to enroll first their employees. 2 big system has created an insurance plan for their employee, and then they're going to market the same product to manage Medicare, definitely. So things are different. Our job as a physician is to educate the doctor every minute, every day when they come across, dissuade them from any kind of managed Medicare as far as possible.
So as a ACO, especially a successful ACO, which are high quality and low cost physician service we provide. And once these ACO patients move to the Advantage plan, so they're leaving the high quality care and going other way. So unless somebody become actively involved in informing the patient like AMA or API or ACO bodies and things like that. So I don't think I see any movement in that direction. David, do you see anything like that? Or Lou, do you see anything like that when you go to the meeting for the ACO meetings, or keep the patient fee for service and support that motion?
Dr. Agwal, the only thing that I see is that the patients trust their physician. And, it's great hearing from Dr. Sanchetti. It sounds like the patients look to him first before making the decision. But what I see a lot is that doctors help the patients make the decision to choose the plan that's right for them, and then make sure that they, as well as their specialists, are in network. Every once in a while, a patient will choose a very restricted plan, and then all of the preferred providers that the PCP typically refers to aren't in. So it's really helpful, like Dr. Sanchetti said, is that they help guide the patient to the plan that is typically the highest quality and results in the best health.
Great.
Thank you, David.
Okay, come on, go ahead. I personally believe this is a great. I
I'm
think,
done, Subodh. Let's ask some of the other people who might have.
yeah, somebody had to come up. Don't even announce your name. Just go and say it.
Please, yes, thank you.
The only thing that I'll say is that the MRA coding is the same, whether you're fee-for-service in the ACO or you're affiliated with a managed care or Medicare Advantage plan. All the documentation requirements, all of the diagnosis coding that we talked about is the same across the board.
Well, we almost there, almost close. So basically, I can tell you that we are going to send you some material and comparing those two systems and what we discovered for service basis that you can do better for the patient. Patient have freedom, and you keep your patient and physician relationship in your side, and you probably make if you do everything what Medicare will tell you to do, you probably make more money serving the patient. So we trying to calculate that together, and we will pass to you coming next week. So unless somebody has something to say, we're gonna thank Carrie and David and Dr. Sacheti. Thank you for coming to the and being a speaker here almost. That's great. So let's other
Thank you.
people join it together. It'll be great.
Thank you so much.
Yeah, and so
Thank
thank you,
you.
Carrie, and we'll see you in 2 weeks.
Okay, great.
Thank you.
Good night, everybody.
Thank you. Thank
Thank
you.
Good night.
Bye bye.
Great job, Carrie. Thank you.
Thank you.